I am awfully glad to be here. I'm Glenda Grant. I'm the Executive Director of the Georgia Rural Health Innovation Center. We're very proud to be here with our partners, GPT. We do a lot of great work together, and I feel like many of you in the room are old friends because we've done work with you and met with you and talked with you as well. If you're not as familiar with the center, we are a state-funded center placed here at Mercer at the School of Medicine because our mission's so closely aligned, and that is to do meaningful research, but also to not just study it, but then turn it around and do meaningful programs and initiatives that are sustainable in rural communities. And that's what we're all about. And so we're very proud to be able to work with people all over the state in the 120 rural communities. Sometimes people will say, oh, we want to come tour the center. And I say, it's very boring. Nothing happens there. The real work happens in the 120 rural communities that we go out into every day. And so we are very proud to be able to be here with you today and to help host this with GPT. I would encourage you, in your folder, there's some information about the center. Please visit our website. It tells a little bit about our team and the initiatives and things that are going on with the center and what we're all about. So we're awfully proud that you're here today. And I want to introduce our first speaker. She is a joy, but I'm going to tell you not what's in the folder. You can read her biography for yourself in there. But Dr. Jean Sumner is an incredible mentor, and she is passionate about what she does, and that is to ensure that there is quality, great rural health and access for health in rural communities in Georgia. And people often ask me what I do and then why I do it, especially in job interviews. They say, why do you want to work there? And I said, it aligns with my mission in life, which is to help people. But even more so, it gives us an outlet. Everything we do every day points back to that mission, to give healthcare access and quality healthcare to rural communities. And Jean Sumner is a great part of that vision. She is the PI for our center and that work that we do, and she laser focuses us on that mission every day. If it is not good for rural Georgia, we're not doing it. If it's not sustainable and going to make a tremendous difference, we're not doing it. And so she's always looking for things, and I tell her when she travels around and talks to people, just please don't have another good idea. Because she runs us ragged, but she always comes back with an idea. I'm just going to tell you. She'll call and text us, and sometimes we get those emails at 3:30, and I think, oh, Lord, it's going to be an early morning. But I'm so proud to introduce Dr. Jean Sumner, and she's going to come and speak with us first today.
While Chris is getting those slides up, I just want to welcome you to Mercer. We're delighted to have you. Glenda's serious when she says that everything we do is focused on our mission. Our mission is changing lives in rural Georgia. We care about cities, but you got enough doctors there. Rural Georgia is in trouble, and I believe the best job you can have on earth is being a small town doctor. So that's the message we give to our students. Just as an aside, if you look across the country, the percentage of MD students in MD programs across the country that grew up rural is less than 5%. There's a reason for that. Rural Georgia schools are struggling some. Economic opportunities in those communities are difficult. People tend to gravitate to cities. At Mercer, I'm proud to say, and the dean really doesn't have much to do with this, so I'm bragging on my staff, we have 52% rural and 70% outside of metropolitan Atlanta. And those 30% that come from the metropolitan Atlanta area will know a lot about rural health. So maybe they'll be kind when the guys from down south call them and need help. I'm delighted to be here. When Glenda and Rena asked me to speak, you know, I hate to say, I kind of waited to look at the topic I was supposed to talk on. And when I saw the topic, I thought, gosh, they want me to talk about the future of virtual health. I can tell you that you are the future of virtual health. And I can't predict it, and I can't tell you what's going to happen, but I can tell you that it has to be part of healthcare. And that's for a reason. I took out the virtual because telehealth, virtual health, whatever you want to call it, I don't like for it to be separated. It's healthcare. And it's quality health care. So when you call it by an extra name, people say, well, I don't know about that, it's not going to work. And I've heard that all my life. And quite honestly, I was one of those non-believers. Some of you know I told the story before, but I was asked to give a speech on rural health at Mercer about 20 years ago. And I listed the 10 things I hated about rural health. Well, they were all fixable, but one of the things was that the Medical College of Georgia, and I have 2 degrees from there, and I'm not talking about medical college, had a president who decided he would put a telehealth unit in my hometown, which was Wrightsville, and I was the only doctor in the county. And they dug a trench from Augusta to Wrightsville, and it cost $500,000. And they brought this machine that looked like a Coke machine with a 7-inch screen, and I think it was black and white, and we were going to do dermatology. So it made me mad. I mean, I was glad to have it, but people wouldn't use it, and I didn't know how to use it, and it was like, oh my gosh, I was the only doctor. $500,000 dollars would have gotten 4 more doctors in those days. It was a long time ago. So I was giving the speech, and I made fun of that project, and I didn't know, but one of the guys from medical college was in the audience. And he stood up and said, Dr. Sumner, if you'd been president instead of Eisenhower, we wouldn't have 4-lane roads. And I said, well, you're probably right, because I'm an environmentalist. I don't really like 4-lane roads. But that said, the next day or two, Georgia Partnership for Telehealth showed up in Wrightsville. And I can't remember who it was, GJ, maybe you, or I don't know who it was, but they said, you don't know what you're talking about. Let me show you what we can do. And so over time, we got a grant, we got a unit, and we did telehealth in my office in Wrightsville for years and saved lives. Michelle Powers was my nurse, and I didn't know Michelle was going to be here. I hadn't seen her in years. But Michelle saved lives in Johnson County through telehealth and with a partnership with Georgia Partnership with Telehealth. And my first day when I showed up for my practice with my brother and my father, my older brother said, you're the nursing home doctor. And I said, the last thing I want to do is go to the nursing home. I don't want to go to the nursing home. I'm an internist. I want to go see sick people in the hospital. But I grew to love nursing homes and to love the people that live there and see the difference it made when you took care of older people right. But telehealth is a major focus of that. And we put telehealth in 4 of the 5 nursing homes that I went to. And some of those homes had the lowest readmission rate in the state because of the telehealth. Because the last place you want a 90-year-old frail individual to go is the ER. And if you could see them and assess them well, and nobody does that better than the people who put those units in, which was the Georgia Partnership. But the blue part of that map is what we've got to address. And that is the health factors that result. And if it's blue or light blue or anything other than the light gray, it costs the state of Georgia a lot of money, and it's detrimental to people's quality of life, and they die. It's the chronic disease. So we have to refocus on patient-centered care. It has to be about the patient. I get an opportunity to talk to a lot of people who are a lot more important than me and probably know a lot more about systems of care than I do. But the thing that discourages me is they never talk about patients. They talk about income, revenue streams, coding, everything but patients. And I am a firm believer that if you put the patient first and build your model around the quality of care, the accessibility of the care, the affordability of the care, and the efficiency of that care, with the patient in mind, you'll make money. And I know that's important. I'm not making light of that. But we don't do that. We don't think about patient first. Telehealth does. Virtual care does. It puts the patient in the forefront, and it respects the obstacles that patient has to overcome. Really, medical care is about us. It's about the time I want to work. I want the weekends off. I don't want to be on call. I sure don't want to go in on Christmas. And that's kind of sad. It's about the nursing shortage, which is terrible. We have a nursing shortage. But a lot of the people in the hospital could have not been in the hospital had we seen them earlier. If you think about the healthcare stream, hospitals are here, and they're great institutions, and we have to protect our rural hospitals and our urban hospitals. I'm not picking on them. I'm just partial to rural.
We need to protect them. But healthcare needs to move to the community. We need to have personal care. You need to know something about your patients, and that's one of the privileges of small towns. You know everything. That may be good, may be bad, but you still know who drinks at night, who smokes in the closet, all those things. When the patient comes in, you need a provider that knows why they're there, who cares about why they're there, who's informed about their past medical history. Don't put it on the patient. Your obligation is to do that. You can do that with telehealth. You need continuity of care. I am shocked, and I know a lot about the care that others get in cities when they never seen the same doctor or the same nurse practitioner twice. There's no continuity. One of the fun things about rural health is intergenerational continuity of care. Continuity of care in telehealth is easy. Doesn't matter if the doctor's sitting at home in his underwear or in the clinic. They can follow up. It needs to be the appropriate care at the right time. But have you been a patient lately? It's really hard to access any care. And Glenda did not say this, thank you, but I don't mind calling up somebody and making it happen for some of my former patients. Michelle can tell you that too. And you need follow-up. You know, we put it on the patient to get their prescriptions, to find out their next appointment, to do all of that things. Telehealth makes care patient-centered. It has to be high quality. You may realize this, that all telehealth is state regulated. It's not national. The VA has a national license. That's because they're in a system of care. I think the military does as well, I'm not sure. But if you're an independent practitioner or health system, you have to use Georgia rules. And that's important. Now, Georgia had reimbursement laws before they had telehealth. And what happened early on in the course of things, and Michelle's in here and she's a lawyer and I don't want to cross the law line, I don't know the law. But we had creepy companies come to Georgia because they were focused on making money and they didn't really care about quality. And so the Board of Medicine, where I was on, felt like we needed to write some rules about it to protect patients, and that was our purpose. And so Georgia established some rules that pretty much aren't changed, but I would urge you to look at them. And as you look at them, they're pretty simple. It says if you have, and it doesn't say this, but this is what it means. I know what the intent was, is if you have a relationship with a patient, you can treat them on the phone, you can treat them through a video chat, you can do all those things. But if you have never seen that individual before, there's certain protections that you need to make sure that the quality of care is the same as in person. Now, if you're covering for a partner, if you're in a hospital system and have access to records, you have a relationship with that patient because you're covering. But that's for new patients. But review those rules. And remember, when you read them, it'll say you have to do this or. So people get confused about that. But they only protect the patient and they stand for good quality care. This is one of the units that was at the nursing home where I was, where the nurse is actually looking at her own ear to show Ms. Davis what her ear will look like in a minute. It has to be accessible. Transportation is one of the most broken parts of healthcare. It's terrible. If you're driving yourself, you can't find a place to park. And if you're sick and have to find a place to park 3 blocks away from where you need to be, it's really difficult. There's millions of dollars put in transportation. I have a theory, and I can't prove it, that one of the problems with maternal mortality is we expect young mothers who may be on Medicaid to get on a Medicaid van, and those vans go through 10 towns before they get where they're going, and there may be 5 other people in the van. But this van pulled up at one of my nursing homes, and I say, this is actually a transportation van that was picking up a patient to see a psychiatrist. If you didn't need a psychiatrist before you got in that van, you needed a psychiatrist when you got out. But think of the money you save with telehealth. Think of the money you save with remote monitoring, because you don't make the patient come. You don't make the patient drive 40 or 60 miles. If you could do this at home, if you could go to a local public health department, every public health department I stayed in there, I saw public health people here, and I love public health, has a telehealth unit. And so there's opportunity there. But you also can have your daughter present on the call. So your daughter's at work and you have a doctor's call. Your daughter could be on the call if you wanted to be. The change of environment in older people or even in sick people can cause a delirium. There's so many opportunities with telehealth. This joke says the stack of books on his bedside table that he's been intending to read for years fell over and crushed him. I kind of feel that way because we talk about the cost of health care, but we talk about it all the time, but we never do anything about it. It just keeps going through the roof. And if you happen to be the poor person that has a heart attack and ends up in a hospital and has to go to surgery, and then you find out the anesthesia group was outside your insurance and you have to pay for it. But it has to be affordable for the patient, for the provider, and for the system of care. So what does that well? Telehealth. You can do pre-op care. You can it decreases need for transportation. You can address problems early in the course of things. You can follow up. If I had a hospital system and I had heart failure patients, I'd give every one of them the opportunity to follow up with a small stethoscope in a day or two. And it has to be efficient. You need a schedule, and patients have a right to an appointment that works on time. And that's one thing that happens in telehealth if you do it right. You set a time, the patient's ready, the doctor's ready, and you can talk to the patient, switch to the next room that may be 100 miles away, come back to the first patient and finish that visit. And they also can do emergent visits. In one of the nursing homes where I worked, we did a cardiovascular clinic for heart failure. And that cardiologist in the morning could see effectively 12 patients. And the families loved it, the patients loved it, the nurses loved it. It happened because there was a champion there. Her name was Sheila. And Sheila would get those records, and the cardiologist had the echo and the last EKG and the lab that was running. They had that in advance. And the patient was ready to go. And they had 2 rooms going, and it worked. But if that patient went bad, they could also have an emergent cardiologist evaluation. You need to prepare. You need to get the records of the patient. They need to be available to the provider that's going to see the patient. And the provider needs to know the purpose of the visit, and they need to be prepared to look at it. You need a team with a leader. And you need a leader in the physician-provider group, and you need a leader with staff. And let me say that the other way. The staff is the most important. And if you walk into any office, it is not the provider that's the best with technology. Ask Michelle. I'll make you stand up or leave, Michelle. And it needs to be on time, but you can accomplish that through using the time wisely on some of the systems. So the future of healthcare through electronic or other such means, which is what the state calls it, is up to you. But it's a great system that really works, that makes it more patient-centered. It provides high-quality care. It makes it accessible, makes it affordable, it makes it efficient. But it will not work till you start adopting it. And it is not rocket science. It's simple. But you got to get your group together and have a team and think about patients, because it is truly what is best for patients. This is my grandfather. And my grandfather finished at Emory before it was called Emory, and he came to Sandersville in the late 1800s. And he used to tell me that when he came into practice, he had a stethoscope, and the doctors who had been there for the last 50 years would make fun of him for using his stethoscope because they just put their ear to the chest. And he said, they'll always laugh at new things, just, figure them out. So if Granddaddy was around, which he's not, he would be proud of telehealth. He would do it. But the things that you know about is that telehealth through stroke really works. Everybody knows that. It saves brain function. David Hess was a new faculty member, and I was a new doctor in Sandersville, and we were one of the first REACH sites. And we'd given a lot of streptokinase and TPA in heart attacks, but nobody had done it in stroke. And when he said, we're going to do this in stroke, I thought he'd lost his mind. And I was the only doctor in the hospital. I mean, we took call for the ER, and you went in if they brought in a stroke. So this guy that I didn't really know well would get on the phone, and that just wasn't working for him. So he figured out through the Georgia Partnership how to do a screen shot, and he would look at the patient with you. And then you'd give him this chemical, and you'd see them go from paralysis to walking and get in the ambulance to transfer to Augusta. And you thought you were Superwoman. It was amazing. I would have never given that shot without Dr. Hess on the other line saying, shoot it, Gene, do it, looking at the scans. That happens through telehealth. You know that. But there's so many other areas where it can help. It brought care to rural communities that you couldn't have. You know, in Augusta, you could go to the medical college, you could go somewhere else. In Sandersville, you couldn't. But we gave, actually, I've been told, and I can't substantiate it in writing, that we gave more TPA for stroke than any hospital in the country that year. It wasn't because of me, but it was because the nurses saw it, the doctors saw it, everybody was in favor of it. It educated a rural workforce. When you have the opportunity to interact with people in urban academic centers that are cutting edge technology, you learn best practices very quickly. It improved health literacy. Now that's the ability to take instructions. And we can talk about that more, and you can be educated and health illiterate. I think I'm a pretty good communicator. I'm probably not, but I went to nursing school and we spent a lot of time talking to patients. I had a lady that came in my office one day, and I thought she was the end of the day and I needed to do a CAT scan on her. And I told her, was trying to figure out if she was allergic to iodine, so I said, do you like shrimp? She didn't know what shrimp were. And this patient had been my patient for a while, and I said, well, Miss Little May, do you eat oysters? And she said, well, I eat oyster stew. And I said, do you have any reaction to it? No, that's fine. I said, do you eat the oysters in the stew? Yeah, I like the oysters. They bother you? No. So I ordered a CAT scan with contrast, and she was the last patient. I ran down to the grocery store to get some milk before I went home, and 2 or 3 people in front of me, there was Miss Lita May. And I said, what you got there, Miss Lita May? And she had a box top, you know, they cut box tops off, and it was full of oyster stew. And I'd spent all this time telling her about the contrast and, you know, but she thought I said, eat oyster stew until we do the CAT scan. And that was not on her, because she was smart. She was smart. She was not educated, but she was a smart lady. And she did everything that I asked her to do. And that made me scared, because I thought, what else is she doing that I can't communicate with? But telehealth improves health literacy and gives you an opportunity to follow up with patients and to make sure they got the instruction right, and it builds relationships. And relationships change health status, and make people healthier. There's so many things that can be done with telehealth, and I could go on all day, and I won't, but Mercer got the first Medicaid waiver for telehealth in an ambulance in Hancock County, working with the Georgia Partnership, and we had 19 partners. And the idea was 70% or more of 911 calls are non-emergent. And you can say what you want and be critical of people who end up in ERs, but if you live in rural Georgia, there's nothing else. And in Hancock County, which is Sparta, it's 30, 40 miles to the nearest hospital. So, and the children live in Atlanta, so you call the ambulance for a ride. That's the only ride you got. So they had one ambulance, and the ambulance would leave the county, and somebody would have a heart attack for a sprained ankle or a bad cold, and somebody would die of a heart attack. So they were looking for a solution. So we were able to work with DCH and get a Medicaid waiver for ambulance care. We put in, with the Georgia Partnership, a great system, and they put a full-time employee in Hancock County, and we put a enhancer on the ambulance that increased the signal, and we even got Governor Deal, who was the governor at the time, who called the telephone companies, the cellular companies, and said, turn on those darn towers. We got a project going on up there. And he did, and we had great reception. We could go into a home, we could connect to telehealth through the ER. If the EMT thought it was non-emergent, we could connect to an ER. We could get a digital quality x-ray at that house read by a board-certified radiologist within an hour. The EMT could draw lab, and the project did not work out. And it didn't work out, not because of the EMTs, not because of the patients, not because of the Georgia Partnership, because we couldn't whip the politics. There was so much politics in that county that we underestimated. But we talk a lot now about paramedicine, and paramedicine is important, but telehealth in the home works, and it can be provided by a person, an Uber driver who's trained. It can be a nurse going into that home. It can be a nurse practitioner going into the home. But it brings primary care home, and that's a good thing if it's done with quality. Medicare Wellness pays good money to providers. Can you do that with telehealth? I suspect so, but you can also do wellness checks, follow-up from hospitalization. There have been multiple projects in the state that showed that EMS do this very well. And so I hope that will expand, whether it's through the ambulance use. In a rural community, if you look at the data, they work 4 to 5 hours a day. And they're good guys, and you want them to come when you need them. But there's time in there to make some follow-up calls. Telehealth helps in ICU consultation. I think you all know that. Emory had a great program, Dr. Buckman at Emory, and that's still sustainable. Emergency department support. I was talking to a pediatrician in a small town the other day, and she said, when I was at CHOA, we did 3 codes a day. And I do maybe 3 codes a year. And to have a telehealth unit in the ER just to remind me and to make sure I cover all those bases would be critically important to her. Surgical consultation. People travel and get their pre-op and they go back home, and then they get their surgery and they go back home, and then they come back and the surgeon goes, looks good, see you in 2 weeks, and they go back home. Follow-up, build those systems that allow telehealth to help that patient not to travel. And if you check the price of gas, there are a lot of reasons not to travel other than it's hard on the patient. This is Miss Davis. She's 104 in this picture, I believe, but Miss Davis fell and broke her hip, and at 102 and a half. She had outlived all but one of her 12 children, but she was sharp as a tack. If you're ever in Tennille, Georgia, she ran the Tennille Hotel. It's right next to the tracks, and she could tell some stories, and I won't get into her stories, but she was an amazing woman. But she fell and broke her hip, and I knew that if I sent her to the hospital, and she was going to come to here in Macon, because it was the closest facility that would fix the hip, and they would put her in the hospital, and they didn't know what she liked to eat, and then she would get confused, and they would give her some Haldol, not saying that was terrible. And then she was a strong woman, and she'd get confused, and somebody might put her in restraints. And if she stayed in that hospital 3 or 4 days, she was not coming back. So I called a young man that had been a medical student of mine who was a trauma surgeon. And I said, John, I got a proposal for you. I said, I'm going to send this 102-year-old lady to you, but I want you to send her back after you operate on her. Don't keep her, because I'm afraid she'll die. She's 102 and a half. He said, I can't do that, Jane. I just can't do that. The hospital won't let me do that. I won the argument, but I promised to be at that nursing home when she got home. And I said, I'll be there, and we'll get her to see you when she arrives by telehealth. And indeed we did. She came back in 23 hours. And I was there, and the nurses were there, and the therapists were there, and we got to talk from their physical therapist to our physical therapist. The nurses presented the patient to him. He never saw Miss Davis again, though he saw her on telehealth. He never saw her in person again. She did great. She never quit walking. She never quit walking. And she died at 105. And she never had delirium. She got over that hip. I said, can you do that? Did the nursing home like it? Heck no. In those days, it took 3 days to get Medicare, and they were not happy with me. I think they've changed that some in COVID, but it wasn't happy. But it was what was best for the patient. And we've got to refocus on what's best for the patient. But you can use it in acute illness. Does a patient need to go to the emergency room? Maybe not. Does the patient have a sore throat? Do they have COVID? What do they have? The post-hospital, they spend a week in your hospital and you say come back in 2 weeks, a lot happens. Did they get their medicine? Did they go back into heart failure? And it can shorten length of stay, as it did in Ms. Davis's case. Maternal health. Georgia is, I think, Natalie, where are we now? We were 50 out of 50, but we got up to the robust 48 out of 50.
Got it.
Yeah. So one of the things in maternal mortality is pregnancy preparation. People get pregnant, but if you really want to have a baby and a healthy baby, think about it. Are you eating right? Are you on a multivitamin? You can do that through telehealth, education, prenatal care, getting ready. The Innovation Center is doing a project, and actually I got some uptake on that last week. It's another idea, Glenda. I'll tell you about it later. Natalie worked on this, and she left us from the center, but she was there doing ultrasound. And there's a project in Douglas, Georgia, that does ultrasound, and we just recently provided an ultrasound for the gentleman. He's an OBGYN, and they do home visits. But it's not for a complicated ultrasound, but routine pregnancy care prenatally can be done very effectively by telehealth. Advanced care with high-risk OB is being done all the time through telehealth. You can hear the baby, and you can do postpartum care for sure. One of the problems with postpartum care is disruption of families. You know, women historically had a mama or a grandmama or somebody to tell them what to do. Families are different. Mothers work. They're not there. They live in different towns. There's so much opportunity to build that care, both in the community, maybe at the health department. I'm living Kalu's health department over there, or at home. The most important thing I can tell you, if you're in a doctor's practice, get that doctor, that community-based practice to put in telehealth. It's cheap, it's effective, and it works. And it also gives you a chance to get a cardiologist to look at the patient that you look at the EKG, make sure that they feel good. Or you can give a report on a patient that helps that transition to a hospital. You can follow up with patients. Why would a diabetic come back to your office in 2 weeks to show you their list of blood sugars, to let you look again at that spot on their toe, and to talk about adjusting their insulin when you can do that so effectively through telehealth? It brings in specialty consultation, and in doing that, it also raises your level of expertise. There is no, I think that mental health is the most important part of healthcare in many ways, and I think that we have so little of it, and there's so many complex obstacles to getting that done. But mental health care, psychiatric care, counseling care really matters. And if you're interested in an amazing project, talk to Joan Anderson. Where are you, Joan? There she is. Talk to her about what the center's doing in public school counseling. Post-op follow-up, as I mentioned, they can come to your office and get their gallbladder incision looked at by the surgeon in a town 60 miles away, and Medicare wellness visits. Health literacy, if anything's orange or red on this map, it's not good. So look at remember the blue map with the health disparities or the outcomes, the factors. Look at the disparities. You can say, and people say, well, the individuals there aren't educated, or they're not smart, or they don't have opportunity. And I've worked there and lived there my whole life, and I will go to bat with them that they are. And they are the poorest family, the most uneducated family wants to do better if they have a relationship with you and you care about them. You can change that map through telehealth. Now I want to show you what you're up against a little bit. And I don't know if you can see this, but this is in Irwinton, Georgia. This is a grocery store. We talk about health disparities and social determinants of health. Meats. Under meats, ice cold beer. Produce. Under produce, cheap tobacco. Under grocery, beauty supplies. Under dairy, human hair. And under frozen, lottery. It's funny, but I can tell you, I pass through that town every morning. And a few weeks back, after a storm, a pine tree had fallen across the road. Somebody had come and cut it at an angle, but they left 6 inches over the white line, and I managed to blow out my tire. So I creeped into the gas station. It was about 6 o'clock in the morning. And you know, when you drive the same route every day, you make friends with the cars on the road. And these guys got out, and I said, is there a place I can get a tire in Irwinton? And they said, are you kidding? No. They said, don't worry, we got you. They went and got their work truck. They came back with a hydraulic jack, and in 10 minutes, I had a new tire on. They wouldn't take a dime from me, no matter how hard I tried to give them money. Now, those guys are my friends, and I see them a lot of mornings. They come in to get their sausage biscuits, and I say, you better watch that, or their six-pack, and I don't drink that till after work. But they're good people, but this economy is killing them. And they come in now, and this is true, they meet the work group there at that station, and they used to come together in trucks, and now 2 of them got motorcycles, little buses. They drive in the freezing cold because it's less gas. they will still be devoted to their families and to health care, but they cannot afford to drive 30 and 40 miles for a sore throat. It can't happen. And we have got to find telehealth ways and find ways to serve communities to help them get out of that. Does anybody know who these guys are? Anybody want to venture a guess? The first guy is Sir Alexander Fleming. He discovered penicillin. And the second guy is Ed Roberts, who invented the first personal computer. Dr. Fleming is dead, and so is Dr. Roberts for that matter, but Dr. Fleming, my father was a physician. He graduated from Tulane, and he said that as a dean of a medical school, I always think they would kill us now for doing this, but he said the dean called him in as fourth-year students and said, guys, because there were no women in his class, I got good news and bad news. The good news is you're going to graduate early. The bad news is you're all going down to the induction station and being inducted into the Army. So they took the entire class down to the station to sign them up for the Army. And Daddy's first assignment was to run a surgery on a ship that crisscrossed the North Atlantic. And they would operate on young soldiers or repair, injuries. They'd pick up the wounded and bring them home. And one day they said, Rollins, you're going to pick up a big brass guy. Daddy said usually was a general or some, military brass. But they picked up Dr. Fleming. And they said, you're going to have to let him bunk with you. So Daddy said he was a really nice guy. And he knew that he had discovered this substance for penicillin. And he said, Dr. Fleming, what do you think they're going to do with this penicillin that you've found? And he said, William, I don't have any idea. I think they'll just inject it around wounds. But the purpose of the travel was to bring him to Boston or to figure out how to use penicillin. He had found it, but he didn't know what to do with it. Dr. Roberts, I met my first day of medical school. He pulled up in his Porsche. I'd never seen a Porsche. He was about 6'5". He probably weighed 325 pounds. And I thought he was a professor, but he was a first-year medical student. And he was in my class, and Ed and I got to be very good friends. But he was the developer of the first personal computer. He also developed the first digital alarm clock, and he was involved in some of the work with the first pacemaker at the University of Florida. He was a biomedical engineer, but he always wanted to be a doctor, and he always wanted to be a doctor in a small town. So he had started a company out in Texas, and he hired two guys to work for him that walked up in his yard and were looking for a job. One was Bill Gates and one was Paul Allen. And after a few years, he sold his company to them for $8 million, and that became Microsoft. And $8 million was a lot of money. But I said, Ed, you ever regret selling that company? He said, I thought computers had maxed out. Nobody ever accused me of being a visionary. And so he was a genius. But he finished medical school and he ended up practicing in Cochran, Georgia his whole life. And if you knew Ed, he probably never told you that story. But while we were in school, Bill Gates would call. And we'd say, who's Bill Gates? And he'd say, some jerk I hired. So my company, we didn't know who it was. But the point is, these great inventors and researchers had no idea where their discoveries were going. And the people who thought up this telehealth system don't really know, but you do know. You know we've got to go back to patient-centered care. And telehealth helps. It will never replace doctors. It'll never, because people come to you because you're a human and they're a human and they want somebody to care about them. But it just opens endless opportunities to improve the quality of care, to improve the level of care, to decrease costs, to cut out some of the unnecessary expense, the burden of travel to get care. So it's a great opportunity for all of us. And as Socrates said, the secret to change is to focus all your energy not on fighting the old, but on building the new. And you can build the new. And it should never compromise patient quality or safety. But there's so much good, and you can provide that good. So thank you so much for your interest in telehealth. Thank you for coming to Mercer. If you got any interested students, we have lots of spots, but we have lots of students competing, and we're really interested in those rural young people. So I'm glad to answer any questions if there's time, but I'm probably running over. Not too bad.